Hello everyone. So for this discussion, we will be tackling the motor system. Your motor system includes your cerebellum, basal ganglia, and your extrapyramidal system. Now let's first discuss your cerebellum. So the cerebellum, also known as your hindbrain, its general function is to maintain our posture and balance, the muscle tone, and for coordination of voluntary motor activity. Now, coordinating your skilled voluntary movements by influencing muscle activity, which will reflect further with your extrapyramidal system. It can also control the equilibrium and muscle tone through connections with the vestibular system and the spinal cord with its gamma motor neurons. So your cerebellum, it has a very strong relationship with your vestibular system. That's why if you are given a scenario wherein your patient has problems with balance, you must first think that there is a possibility that the cerebellum is affected. Now, as to the coordination of voluntary muscle movement, as might be predicted from the cerebellar homunculi, which we will discuss later on, the vermis is the specific part of your cerebellum that controls coordination and muscle tone of the trunk, whereas each cerebellar hemisphere controls your motor coordination and muscle tone on the same side of the body. So I want you to remember that with cerebellum, it controls the same side of the body. It's different from your cerebrum. Remember, your cerebrum has a function contralaterally. So it involves the contralateral side of the body. While your cerebellum, this involves the same side of the body. So when you have problems with cerebellum, it should reflect with the same side. So kung may problem on the right side of the cerebellum, there should be a problem with coordination. For example, on the same side, sa right side din dapat, yung problem with coordination. Now, let's go further with the specific functions. So this is again a part of your motor system. It's the one that executes your smooth sequential movement. So smooth meaning there should not be a jerky movement when we're doing activity or task. Say for example, you are reaching for a glass. When we do that activity, it should be smooth, coordinated. So when we see a problem, kunyari mga jerky movement or what we call tremors, that can signal us that the cerebellum may be affected. Okay, it also controls adjustment, timing, trajectory, and velocity of movement. Later on, we will discuss the different pathologies involving your cerebellum. We have a specific term for each symptoms when it comes to cerebellar affectation. It has no direct pathway to the lower motor neurons, so that's another special function or definition or description with your cerebellum. Again, it has no direct pathway to the lower motor neurons. It exerts its control through the brainstem and cerebral cortex, and it permits voluntary movements to take place smoothly with precision and economy of effort. Okay, so I am emphasizing the word voluntary because there is another system that involves coordinated motor activity but for involuntary motion. So your cerebellum, this is for voluntary movement. Okay? Next, we have its afferent function. When we say afferent, it receives signals. No, receives signals. While your efferent, one way of remembering the difference between these two is when you say efferent, I think of the word exit. They have the same letter E. Diba? So efferent, it exits. So it moves away from the brain. So afferent receives signals. Your efferent, they send signals. Okay, so let's first discuss the afferent functions. So this receives major afferent tracts from the cerebral cortex, your pons, medulla oblongata, and the spinal cord. Again, they have no relationship with lower motor neurons. Now, so lower motor neurons, this is found beyond your anterior horn cell in the spinal cord. But all of the upper motor neurons, they are in the higher cortical regions, such as your cerebrum, and your brainstem. They are upper motor neurons, right? And also your spinal cord is also included under your upper motor neurons. And then it receives afferent vestibular impulses from the labyrinth directly and via vestibular nuclei. We will discuss this again later on. It receives auditory and visual impulses via the inferior and superior colliculi, receives proprioceptive and exteroceptive impulses from the head, neck, and body, which is very important for posture, receives proprioceptive and exteroceptive impulses from the whole body via relay in inferior olive, which is also important for posture and balance. Next, we move on to the efferent. Again, when we say efferent, this sends signals. So, send signals away from the origin. So, its function is to influence, again, ipsilateral motor activity. When we say ipsilateral, it's the same side of the body. Influences also ipsilateral muscle tone. Okay, so I want you to remember that motor activity is different from muscle tone. Okay, so muscle tone, this is the muscle's ability to resist passive motion. Okay, muscle tone again is the muscle's ability to resist passive motion. Okay. So again, this is the part of your cerebral cortex and its relationship with each or with other systems such as your basal ganglia, your thalamus, and your cerebellum, plus your part of your brainstem and also your medulla oblongata going to the spinal cord, which will now have an effect with the movement and will also be the one receiving sensory information that will transmit all this information back to the medulla and then going to the thalamus and then lastly going to the cerebral cortex. So now let's move on with the gross appearance and location. So this is now the anatomy of your cerebellum. So your cerebellum, this is situated in the posterior cranial fossa and it is covered superiorly by the tentorium cerebelli. So that's why also the other name of your cerebellum is your hindbrain, remember? So this is found posteriorly, specifically at the posterior cranial fossa. This is the largest part of the hindbrain and it is found posterior to the fourth ventricle, pons, and medulla oblongata. It is ovoid in shape and constricted in its median part and it has narrow ridge-like folds termed folia. So it's a very distinct feature of your cerebellum, what we call this folia. So remember that it has a name and it is called folia. So this is again the ridge-like folds, yung mga folds natin in the cerebellum. Now, what I want you to remember also in this slide is the fourth ventricle. Right. This one, your fourth ventricle. Why? Because the location of the fourth ventricle, which is ventral to the cerebellum, ventral meaning anterior, no? It is anteriorly situated from the cerebellum. If there is a mass or a lesion in the fourth ventricle, mas common is there would be increase in the pressure or increase in the fluid because in the fourth ventricle, dumadaan yung ating fluid in there, diba? So if there is swelling in the fourth ventricle, what will happen? There could be an obstruction with your cerebellum. So, pag lumaki yan, maiipit, no? Mai-impinge si cerebellum and that could be a cause of problem. Now, why your patient is having yung mga symptoms that we will tackle later on. So, that could be incoordination, balance problem, posture problem. Okay, this is a common manifestation with hydrocephalus. No? So, that's why with patients that are diagnosed with hydrocephalus, the cerebellum may be affected, no? And they may present with mga incoordination problem. And that's because of the obstruction or impingement happening with your cerebellum. Next, we have your hemispheres, no? So, with your cerebellum, you have two hemispheres, which is connected by a narrow median called your vermis. This one is your vermis. Okay, so these hemispheres are further subdivided into three main lobes. We have the anterior, posterior, and the flocculonodular lobe. So each hemisphere of this cerebellum has its own function, has its own unique function. So later pa, we will further discuss these sublobes of your cerebellum. So just remember again that this median, narrow median, this one is your vermis. Okay. Now, the connections of your cerebellum to the brainstem. Kanina, dun sa table, we saw that there is a connection between the cerebellum and the brainstem. So, they are connected through three symmetrical bundles of nerve fibers. It's your superior cerebellar peduncle, your middle cerebellar peduncle, and your inferior cerebellar peduncle. Okay? What's important is that you identify which specifically in the brainstem are they connected. Okay, so your superior cerebellar peduncle, this one is connected to the midbrain. Okay, so si midbrain, di ba, siya naman talaga yung nasa most superior, no, not most. It is found in the superior part of your brainstem. While your pons, it's in the middle, so middle cerebellar peduncle, and then inferior to that would be your medulla oblongata, which is connected with the inferior cerebellar peduncle. Again, these are the tracts in the cerebellar peduncle and their function. So we have again the superior cerebellar peduncle, which connects to the midbrain. So specifically, ito yung mga tracts nila, no? Peduncle kasi it's a collection of tracts. No? So these are the tracts entering the cerebellum. So pag sinabi natin entering, they have afferent or efferent. So if it's receiving or entering, it's afferent. No, we would say that this is an afferent tract. Now, if it's leaving the cerebellum, this would now be an efferent tract. Okay, so your ventral spinocerebellar tract is for the proprioception and exteroception of the lower limb. Your tectocerebellar fibers for visual input. Your trigeminocerebellar fibers for the proprioception from mesencephalic nucleus. Your hypothalamo-cerebellar fibers for somatic visceral integration. Your coerulocerebellar fibers for the noradrenergic modulation of cerebellar learning. So these are all your fibers entering the cerebellum. While for the fibers that exit the cerebellum, it's your cerebello-rubral fiber, which is from the dentate, emboliform, and globus nuclei for fine motor coordination and muscle tone. Your cerebellothalamic fiber with the same function. Your cerebelloreticular for somatomotor and autonomic modulation. Cerebello-olivary fibers for GABAergic feedback. And your cerebello-hypothalamic fibers for the cerebellar autonomic modulation. Now, we have your middle cerebellar peduncle and your inferior cerebellar peduncle. Again, your middle cerebellar peduncle, this one connects with your pons. While your inferior cerebellar peduncle, this one connects with your medulla. Okay, so I won't be reading the names and the function of each tracts. So you can screenshot this if you want for reference. Okay, next we go to the external anatomy. So we have the fissures first. Now, so when we say fissures, these are lines or deepening between lobes that separates each lobe from each other. Okay, so we have three. We have primary, uvulonodular, and your horizontal fissure. So with this picture, we cannot see the primary fissure because your primary fissure can be appreciated in the superior view, no? But this one kasi it's lateral. But later, on the next slide, we'll have an example. So your primary fissure separates your anterior lobe to the posterior or middle lobe. So your posterior lobe of your cerebellum may also be called as the middle lobe. So next, we have uvulonodular fissure. This one. This separates your middle or posterior lobe and the flocculonodular lobe. Your flocculonodular lobe, it's later, we'll show you on the next slide, your flocculonodular lobe. And then lastly, we have the horizontal fissure, which separates the superior from the inferior surfaces. Okay, now your horizontal fissure, this has no morphologic or functional significance. So it serves lang to be a landmark, no, that separates the superior from the inferior surface. Okay, now this is another picture of your lobes and your fissures. So in this slide, you can see the flocculonodular lobe, no? So this is the anterior lobe. Again, your vermis, which is the median of your cerebellum. And then you have your posterior or your middle lobe. And then you have your flocculonodular lobe. So in this one, you can see the primary fissure. So it separates the anterior from the posterior lobe. Now, we're done with the fissures. Let's move on with the lobes. So we have three main lobes of cerebellum. As mentioned earlier, we have your anterior, posterior or middle lobe, and your flocculonodular lobe. Okay, so this one is important to remember with your cerebellum because each lobe has its own function. Okay, so your anterior lobe, let's first start with the anterior lobe. Again, this is your anterior lobe. This has many names. Now, your lobes of cerebellum has many names. So this is also known as your spinocerebellum or your paleocerebellum. Please remember these other names. Okay, again, your anterior lobe can be also known as your spinocerebellum and your paleocerebellum. This one is for the propulsive stereotypical movements such as walking. It is also the one responsible for the regulation of muscle tone. Okay, so again, this is your anterior lobe. This lies anterior to the primary fissure, which is this one. This receives input from stretch receptors or your muscle spindles and Golgi tendon organs via your spinocerebellar tracts. This one plays a role in the regulation of muscle tone. Remember that. Okay? So, pag tinanong kayo, your patient has hypotonicity, meaning mababa or decrease yung muscle tone ni patient. So, that's a problem, no, with the muscle tone. And the cerebellum is affected. You will be asked, what specifically or what lobe specifically is affected if your patient presents with hypotonicity? You should be confident, no, in answering, it's the anterior lobe or the paleocerebellum. Okay? So, aside from that, again, it's also for stereotypical movement, no? So, pag sinabing stereotypical movement, it's almost like automatic na mga activity. Or coordinated, and well, may mas specific for coordination. But this one, stereotypical movement, no? Such as, number one example would be your walking or ambulation. Now, let's move on to the next lobe. Now, we have your middle or posterior lobe. This one, yung malaki, no? Siya yung pinaka-bulky na part ni cerebellum. So, this is also known as your cerebrocerebellum and your neocerebellum. So, kanina, paleo for anterior. This one is neocerebellum. So, this one is the specific lobe for coordination. Kaya sabi ko kanina, I took it back, no? Baka malito kayo pag sinabi kong coordinated activity or muscle activity. So, this one yun. See, posterior lobe, no? Specific for coordination of voluntary motor activity. Diba? Paulit-ulit yung voluntary. Okay. So, again, this is known as your neocerebellum or your cerebrocerebellum. So, this lies between the primary fissure and the posterolateral fissure. So, this receives massive input from the neocortex via your cortico-pontocerebellar fibers. This one plays a role in the coordination of movement. Specifically pa, coordination of fine movement. So, yan. See? Posterior cerebellum or posterior lobe of cerebellum. Next, we have your flocculonodular lobe. So, this is also known as your vestibulocerebellum and your archicerebellum. So, ang dami ng names. No? We have paleo, we have neo, and we have archicerebellum. So, this one is for maintenance of posture and balance. Okay, posture and balance. And also, coordination of eye movement. So, this is specific to the eyes. Kanina, it's coordination of voluntary muscle activity. Your flocculonodular lobe is specific to eye movements. Okay, so if you have patient affected yung cerebellum nila and they present with balance problem, example would be an ataxic gait, they could present with impaired balance. So, your flocculonodular lobe, this one, might be affected. Okay? So, again, your coordination of eye movement, this is also a function of your flocculonodular lobe. So, coordination of eye movement, when this is impaired, the common symptom is what we call nystagmus. So, nystagmus is a jerky movement or oscillation of the eyes. So, that could also be a problem with cerebellum. However, guys, the presentation or the clinical manifestation nystagmus does not highly suggest a cerebellar problem or lesion. Kasi may other system pa that could also present with nystagmus. So, why am I saying this? It could be lang, no? You can differential diagnose the affectation of your cerebellum when a person presents with nystagmus. Kasi again, you are certain that coordination of movement is a function of the cerebellum, specifically of the flocculonodular lobe. Now, in this slide, eto, tinable ko na, no, yung mga function and clinical findings that you can see if the lobe is affected. Now, balik tayo with anterior lobe, no? So, anterior lobe, it has a phylogenetic name of paleocerebellum. Other name again also is your spinocerebellum. So, this one is for stereotypical movements such as walking and also for muscle tone. Muscle tone, stereotypical movements. So, the clinical finding would be truncal problems. So, makikita nyo may mga postural swaying. No, pwede yun. Truncal problems and impaired, yun nga, muscle tone such as hypotonia. No, so, truncal problems, ayan, and also ataxia. Truncal ataxia. And then we have middle or posterior, also known as your neocerebellum. This one also is known as cerebrocerebellum or pontocerebellum. This one is for coordination. And the clinical findings, if this is affected, would be intention tremor. Okay, so intention tremor, this is most evident sa hand. So, for example, you are reaching a glass of water. So, dapat, again, diba, smooth dapat yung activity natin. But if you have problem with the neocerebellum, there would be shaking of the hand while attempting to do the activity. Now, so, remember intention, kasi we have another type of tremor which is known as your resting tremor. It's different from intention tremor. Pag sinabing intention, lumalabas lang yung tremor through activity, no? Or upon doing an activity. But with resting tremor, which is not evident with your neocerebellar affectation, your resting tremor, it shows at rest. Walang ginagawang activity, nakikita nyo, nanginginig yung kamay. That's your resting hand tremor. Okay, so specific tong intention tremor natin for cerebellar affectation. Kasi with your resting tremor, this one is more specific to your Parkinson's disease, no, which is affectation of the basal ganglia. So that's another system. No? So, I want you to remember lang yung intention tremor. So, possible symptom could be dysmetria. So, overshooting yan. Okay, so dysmetria, say for example, you are instructing your patient to reach your finger. So, may finger in front of your patient, and then you ask your patient to point his or her finger from his nose going to your finger. So, 10 times yun, paulit-ulit. So, nose to finger, and then if there is dysmetria, you would see that your patient has a tendency to overshoot. No, nag-overshoot sila doon sa finger nyo. That's a sign of dysmetria, and that's a problem with your neocerebellum. Okay, and then we have last, your flocculonodular, also known as archicerebellum, or your vestibulocerebellum. So this one is for posture and balance and vestibular. And also eye coordination. So you will have a balance problem if this is affected, and you may present with nystagmus. Okay? So this is your lobes of your cerebellum. So please remember the other names, and the function responsible with each lobe. Again, this is just another table showing the functions of your different lobes. So I won't be reading the table. You may opt to screenshot this slide. Now we have the external anatomy of the cerebellum. So we're done with the internal. We go now to the external. So we have the somatotopic organization or the longitudinal, no? It's called longitudinal kasi kanina yung mga fissures natin pag ganito, 'di ba? Now we have the longitudinal, which is pag ganito naman. So we have the vermal, the paravermal, and the lateral. Okay, your vermal, this is found in the vermis, no? So vermis, wait. The cerebellar nucleus that is connected with this is the fastigial nucleus. You have your paravermal or the intermediate, this one. It's with the medial region of the cerebellar hemisphere. And its cerebellar nucleus is the interposed nuclei. And then lastly, the lateral or the hemispheric, which is in the lateral region of the cerebellar hemisphere. This one naman is specific to the dentate nucleus. So again, vermis, fastigial nucleus, intermediate or your paravermal, interposed nuclei, and then the lateral or the hemispheric, your dentate nucleus. Okay, now let's go with the effects of lesion with this vertical divisions. So you have your wide base gait, difficulty with tandem gait, titubation of head and body. So this will present if you have a problem with the vermal and the paravermal. So when we say wide base gait, yung malayo yung feet nila from each other. So that is a sign actually of balance problem. Natakot silang mahulog, ma-fall. Kaya yung base of support nila, they increase it, no? So lessen din yung risk of fall nila. That's a sign of balance problem. Then you have difficulty with tandem gait. So tandem gait, again, this pose a challenge with balance, no? So if they have problem doing tandem gait, definitely it means that they have problem with balance. No? It's a very challenging activity to do for balance. Titubation of the head and body. So if you have truncal problems, titubation is para silang nag-rock back and forth, yung head and body nila, or nag-shake Okay, para siyang tremor but in the head and the body. So nagsishake yung head and body nila. That's what we call titubation. And then you have your spontaneous nystagmus. Again, this is yung oscillation of the eyes. Okay, now this is specific to the lateral hemispheric. Okay, so this is also for motor planning and conscious assessment of movement errors. So you will have ataxia. Lesions to this area would result to ataxia, nystagmus, delayed initiation and termination of motor activity, abnormal stance and gait, which may be a result of balance problem, decomposition of movement, hypotonia, which is decrease in muscle tone, dysarthria, which is problem with speaking, dysmetria, which is overshooting on a focal point, dysdiadochokinesia, problems or impairments with alternating motion, dysrhythmokinesis, problem with rhythm of a movement, impaired check, and lastly, impaired check and rebound. Now, with the internal cerebellum, internal anatomy of cerebellum, you have your layers of the cerebellum, specifically your molecular, Purkinje, and the granular layer. And you also have your mga white matter and nuclei natin, which will be discussed in the next few slides. Okay, so let's move on with the internal anatomy. So first, the outer covering of your cerebellum is composed of gray matter. Okay? Gray matter, remember that. And it is called your cerebellar cortex. Okay? So yung gray matter natin, outer covering of is your cerebellar cortex. And then the inner covering is composed of the white matter. Okay, this one, white matter. And then the outer covering is the cerebral cortex, na yung gray part, that's your gray matter or the outer covering. So, embedded in the white matter of each hemisphere are three masses of gray matter forming your intracerebellar nuclei. So, each fold or volume contains a core of white matter covered superficially by your gray matter. So, your arbor vitae, ito yun. Yung mga nakaganyan, parang mga kamay, that's your arbor vitae. Okay, and then this is your white matter. And then again, the covering of, yung naka-cover on top of your your white matter is your cerebellar cortex or your gray matter. Again, this is your vermis found in the middle. And then your deep cerebellar nuclei embedded inside the white matter. Okay, nasa white matter sila. Okay, so this is another way to identify the internal anatomy of your cerebellum. So let's go first with the gray matter, which is again found in the outer covering of your white matter. So it has the nerve cell bodies, specifically your deep cerebellar nuclei, which is again embedded inside the white matter. So naka-embed to dito. So again, this also covered your this is known as your cerebellar cortex. So your deep cerebellar nuclei are divided into form. You have your dentate, emboliform, globose, and fastigial. Now, so your emboliform and your globose are also known as your interposed nuclei. No, kanina nabanggit natin siya with your intermediate division, vertical division. So that is your interposed nuclei. Again, it's your emboliform and your globose nucleus. Now, for the white matter, this is divided into three. You have your intrinsic fibers. Okay, so yung white matter natin, it's a collection of fibers. No, kaya siya also white because it's fiber. So you have your intrinsic fiber, your efferent fiber, and your afferent fiber. So the intrinsic fiber originates at the cerebellar cortex, and then termination would be at the deep cerebellar nuclei. So yung intrinsic fiber, it's located inside the cerebellum lang. Hindi sila lalabas ng cerebellum. While your efferent or your output fibers originates from the deep ito dito, deep cerebellar fibers, nuclei, sorry, deep cerebellar nuclei, and the cerebellar cortex. And then they will terminate to the extra cerebellar location. So, lalabas sila. So, from the deep deep cerebellar nuclei, lalabas sila sa cerebellum. And then you have that's your efferent, no? Exits. Afferent, so manggagaling yan sa labas, originates at the extra cerebellar locations. So, pwedeng spinal cord, pwedeng brainstem, and then they will terminate at the cerebellar cortex and the deep cerebellar nuclei. So, that is the internal anatomy of your cerebellum. Now, let's move on with the deeper discussion about these cerebellar nuclei. So, for the gray matter, again, it's also known as your cerebellar cortex, and it has 3 layers from outer to inner layer. You have your molecular layer, your Purkinje cell layer, and your granular layer. Okay, so superficial, it's the molecular layer. This one. You have your Purkinje layer, this one. And then you have your granular layer, which is the deep layer. So let's start with your molecular layer. So again, this is the superficial layer of your cerebellar cortex. It has 2 types of cell in this layer. You have your outer or external stellate cells and your basket cell. Okay, so your stellate cells, they are located in the molecular layer and will receive excitatory inputs. Okay, excitatory inputs. Primarily from the parallel fibers. Yung parallel fibers, it's adjacent fibers, no, malapit sa stellate cells. No, so, these cells give rise to inhibitory synapses on Purkinje cells. So, they will receive excitatory inputs, but their function is to inhibit. Okay? Inhibit Purkinje cells. After that, we have your Purkinje layer, which contains your Purkinje cell bodies, which is an important part of your cerebellar cortex because this is its functional unit. And why is that? Because its axons, which is this part, forms the principal output. Output meaning efferent signals of the cerebellar cortex. So this run downwards through the granular cell layers to synapse with the deep cerebellar nucleus, which is embedded in the white matter. So this, your Purkinje layer, your Purkinje cell will now inhibit your deep cerebellar nuclei. Now, let's go with your granular layer. Now, your granular layer contains your granule cells and your Golgi cells, also known as your interstellate cells. So, your granule cells, this one will form its axons, no? And axons actually will be the one forming your parallel fibers. Okay, so again, your Golgi cells, this is this will form your parallel fibers. So these axonal branches of granule cells will be called now your parallel fibers. They are actually extremely numerous, no? The parallel fibers are also therefore abundant, and they almost fill the molecular layer. As you can see, this is the parallel fibers. So, abundant yang parallel fibers natin. And they will synapse with the dendrites of your Purkinje and the outer stellate basket and Golgi cells. So, di ba remember, your parallel fiber is the one that sends excitatory input to your stellate and basket. So, they will come from the granule cells, and they will form again these axons called your parallel fibers to send excitatory signals to your stellate and basket, which will then inhibit your Purkinje cell. Okay, and that's why your granule is an excitatory cell. Then your Golgi inner stellate, this one naman is inhibitory to your interneurons, parallel fibers, mossy fibers, and climbing fibers from excitatory synapses with the Golgi cells. So this is another table showing you the neurons and its location. So again, you have two neurons in the molecular layer. You have your outer stellate and your basket cells. This inhibits your Purkinje cells. Your Purkinje cells, this inhibits your cerebellar nuclei or your deep cerebellar nucleus. And then your granule cells and the Golgi cells, no, each will, your granule for excitatory, and then your Golgi for inhibitory. Okay, now let's move on with the cerebellar cortical mechanisms. So we are done discussing the layers of your cerebellar cortex and its neurons or cells embedded inside. Now let's move on with the mechanism. So there are two main lines of input to the cortex that are excitatory, and those are your climbing fibers and your mossy fibers. Now your climbing fibers, these are the terminal fibers of your olivocerebellar tracts. So olivocerebellar tracts. While your mossy fibers, these are the afferent axons from the pontine nuclei, spinal cord, vestibular nuclei, and reticular formation. So, afferent axons from extra cerebellar areas. Okay, so both of these basically are found outside the cerebellum. So, these are afferent fibers outside the cerebellum. Your climbing fibers and your mossy fibers, which stimulates or sends signals to your Purkinje cells. And again, the function of your Purkinje cells is to inhibit. They are inhibitory to the deep cerebellar nuclei. So if this sends excitatory signal to your Purkinje will therefore inhibit the function of your deep cerebellar nuclei, and that will also inhibit the action to the brainstem, cerebral cortex, and spinal cord. But you also have your inhibitory interneurons, which are your stellate, basket, and your Golgi cells, remember? So once they send inhibitory input to your Purkinje, this one inhibitory, the function of your Purkinje cell to inhibit your deep cerebellar will be eliminated. So wala nang Purkinje, so therefore the function of your deep cerebellar, which is to send signal to your brainstem, cerebral cortex, and spinal cord, will be achieved. No, and that is why with this cortical mechanism, as you would notice, there is a fluctuating inhibitory impulses no being transmitted by the Purkinje cells, kasi sometimes it is excitatory, sometimes inhibitory, no? So that again will modify muscular activity through the motor control areas of the brainstem and cerebral cortex, no? So that's why it's the functional unit of your cerebellar cortex. So the result of this fluctuating inhibitory, excitatory is coordinated motor activity. Okay, so the result is coordinated motor activity. Okay, so example na nga lang would be drinking a glass of water. So, of course, in drinking a glass of water, it should be smooth. No? It should be controlled. So, through this cerebellar cortical mechanism, there are certain muscles that should be stimulated and there are certain muscles that should be inhibited. Diba? So, kailangan hindi mag-contract, for example, si wrist extensors. No? Or kailangan ang mag-contract lang is si flexor. So that is why there is fluctuating inhibition from these areas to result again with coordinated activity. Okay, so just remember, you have excitatory, climbing fibers, mossy fibers. Yung inhibitory interneurons natin will be excited by your parallel fibers, diba? Parallel fibers, which are the axon of your granule cells, no? So this is granule cells, axons of your granule. And then your stellate basket Golgi, they are inhibitory interneurons to your Purkinje cells. Your Purkinje cells sends inhibitory input to your deep cerebellar nuclei. Your deep cerebellar nuclei is where your brainstem, cerebellar cortex, and spinal cord synapse with at the level of your cerebellum. Next, we have the white matter. So we're done with the cerebral cortex, cerebellar cortex, or your gray matter. Now let's have white matter. So your white matter, this is also known as your medullary center or medullary white matter, containing myelinated axons. Okay, so they have intrinsic, efferent, and afferent. So when we say again intrinsic, these are found within the cerebellum. So you have the origin at the cerebellar cortex and terminates at the deep cerebellar nuclei. Efferent fibers is coming from the deep cerebellar nuclei and cerebellar cortex and will terminate at the extracerebellar locations, while the afferent will come from the extracerebellar locations, terminating at the cerebellar cortex and deep cerebellar nuclei. Now let's go to the deep cerebellar nuclei. So this is still part of your gray matter. Although it is situated inside the white matter, it's still a part of your gray matter. So they are embedded in the central core of white matter. Masses sila of gray matter, which constitute your cerebellar nuclei. So from lateral to medial, they are your dentate nucleus. Wait, this is your dentate nucleus from lateral. You have your emboliform nucleus. You have your globose nucleus and your fastigial nucleus. So the axons of the intracerebellar nuclei will form the cerebellar outflow in the superior and inferior peduncles, cerebellar peduncles. So the fastigial nucleus will receive fiber from the vermis. So since this is found in the middle, no, so this will receive fibers from the vermis. The globus and the emboliform nuclei form from the paravermal regions, and the dentate nucleus from the lateral region. So the cells in the deep cerebellar nuclei receives inhibitory input from the Purkinje cell, remember? So they also receive excitatory input from sites outside the cerebellum, including the pontine nuclei, the inferior olivary nucleus, the reticular formation found in the spinal cord, your locus coeruleus, and your raphe nuclei. Inputs giving rise to the climbing and mossy fibers also project excitatory collaterals to the deep cerebellar nuclei. As a result of this arrangement, cells in the deep cerebellar nuclei receives inhibitory inputs again from the Purkinje cells, and then excitatory inputs from other sources, more of extracerebellar sources. And then cells in the deep cerebellar nuclei fire tonically at rates reflecting the balance between the opposing excitatory and inhibitory inputs that converge on them. That's why your cerebellum really has a big effect with coordination of muscle activity. Okay, now let's go again with the different nuclei. So you have again fastigial, which is specifically for posture, balance, muscle tone, eye movements. Iba pa to dun sa mga anterior, posterior lobes natin and flocculonodular lobe. No, this one is the this is the deep cerebellar nuclei naman. So again, fastigial receives input from the vermis. It's for the posture, balance, muscle tone, eye movements. Your interpost for locomotion and extremity coordination. Your dentate is for finely coordinated movements and movements of distal limbs. So afferent fibers entering the cerebellar cortex, these are like the major tracts, no? So we have from cerebral cortex, or from the brain, we have corticopontocerebellar, you have cerebro-olivocerebellar, cerebro-reticulocerebellar, and from the spinal cord, we have the ventral spinocerebellar, and your dorsal spinocerebellar, and your cuniocerebellar. Now, let's discuss them one by one. Let's start first with your corticopontocerebellar. So, from the name itself, guys, it will be easier for us to remember what is the origin and destination of this tract. So, cortico will come from the cortex or the brain. It will pass through the ponto or the pons or pontine nuclei and the cerebellar, which is cerebellum. So, the function of this pathway is to convey control from the cerebral cortex, this one, from the cerebral cortex, specifically frontal, parietal, temporal, occipital lobes, going down to the pontine nuclei, and then mossy fibers to the cerebellar cortex. So this is again an afferent fiber, so they will send sila ng excitatory input either sa Purkinje fiber. Next, we have the cerebro-olivocerebellar. So this one naman will come from still your cortex, cerebrum. So you have your frontal, parietal, temporal, and occipital lobes, and it will insert or send signal to the cerebellar cortex via your inferior olivary nuclei and climbing fibers. So this one conveys control from the cerebral cortex for movement planning, still initiation, monitoring, and adjustment. Next, your cerebro-reticulocerebellar. This one comes from the cortex still, but specific to the sensory motor areas, no? And then it will reach your reticular formation. So via reticular formation, and then it will reach the cerebral cortex. So this one also for movement planning, initiation, monitoring, and adjustment. Next, we have coming from the spinal cord. So we have anterior spinocerebellar. This conveys information from muscles and joints of the upper and lower limb. So origins from muscle spindle, tendon, organs, and joint receptors, and it will synapse with the cerebellar cortex via your mossy fiber. Posterior spinocerebellar, this one, conveys information from muscle and joints of the trunk and lower limbs. So this one specific to the trunk and lower limbs. Your anterior is for upper and lower. Your posterior is for trunk and lower limbs. So same origin, muscle, spindle, tendon, organs, and joint receptors, and same destination. Your cuneo-cerebellar. Diba kanina nabanggit na natin si cuneo, it's for the upper limbs. Upper yan. Cuneo-cerebellar. So, conveys information from muscles and joints of the upper limb and upper part of the thorax. It originates from the nucleus cuneatus of the medulla, and then it will synapse with your cerebellar cortex via the mossy fibers. Next, you have your vestibulocerebellar. So, this one, it conveys information of head position. Nabanggit na rin natin to kanina. Head position and eye movement. So, it will originate from the utricle, saccule, and semicircular canals and the vestibular nuclei, and will synapse with your flocculonodular lobe. So, this one is specific to the flocculonodular lobe via your mossy fibers to cortex of the flocculonodular lobe. So remember, diba, your flocculonodular lobe, this is specific to eye coordination. So via your vestibulocerebellar, it will receive input from the vestibular system. Next, we have the tectocerebellar. So tectocerebellar, it will originate from the tectum of the brainstem, both your superior and inferior colliculi, and it will synapse with your cerebellar cortex via mossy fibers. The function of this tract is for reflex head turning due to auditory or visual impulses. So, for example na lang is, pag may tumawag or tatawid, no? Kunyari, passing through the road, and then may nag-honk ng car. So, reflex natin is you will look at the sound, di ba? So, that is an example of your tectocerebellar. So, reflex head turning due to auditory or visual impulses. So, pag may nag-honk ng car, kunyari sa left side, bago ka tumawid, the reflex is titingin ka kung saan yung sound coming from. So, that is ang responsible na pathway for that would be your tectocerebellar. So, still a function of your cerebellum. Okay, now we're done with the afferent. So, those are all pathways that will send signal from outside the cerebellum going to the cerebellum. Now, let's have the efferent pathway exiting the cerebellum. So, we have your globus emboliform rubral, the dentothalamic, fastigial vestibular, and the fastigial reticular. Now, let's talk about your globus emboliform rubral. So, this one influences ipsilateral motor activity. So, in general, your cerebellum has an effect, no, in controlling ipsilateral motor activity. So, one pathway responsible for that would be this one. So, your globus emboliform rubral, nandun na sa name, no? It comes from your globus and emboliform nuclei, which is found here. Now, I want you to remember this kasi this will cross on the other side. But why or how is that? Even when it crossed, it still commands the same side of the body. So, bigyan mo natin laterality. So, let's say this is the right, this is the left side. So, the globus and emboliform of the left side, no, it will synapse to the other side of, or contralateral side na red nucleus. So, this is the red nucleus. But, magsa-synapse siya on the other side. So, this one, sa right red nucleus. Okay? And that will form your globus emboliform rubral pathway. So, how does it command the same side? So, pag sinabi natin same side, it should be the left muscles pa rin, di ba? Eh, kung nag-cross dito, wouldn't it command the right side of the body? So for this one, hindi. And that's because of the rubrospinal tract. No, so this is the rubrospinal tract. Oh, nag-cross siya ulit pabalik sa left and then down to the muscle or spinal cord and then down to the muscle. And that's why it will have an ipsilateral effect pa rin to the body. Okay, I hope na-gets po, no? Paano naging ipsilateral si globus emboliform rubral. So again, this influences ipsilateral motor activity. Next, we have the dentothalamic. So this is also influence your ipsilateral motor activity. So from the dentate nucleus going to the contralateral ventrolateral nucleus of thalamus. Thalamus. Okay, so this is your dentothalamic. So starting ulit tayo sa dentate nucleus going to the contralateral ventrolateral nucleus of thalamus. This is your thalamus. So again, this is the right, this is the left, contralateral. So right thalamus, no? And then it will go to the contralateral motor cerebral cortex. So sa left, no? To cerebral cortex. And then corticospinal tract crosses the midline and controls the ipsilateral motor neurons in the spinal cord. How is that? So once na-reach na sa cerebral cortex, your cerebral cortex will now send afferent signals to your corticospinal fibers, which will then cross, no, ito, at the midline, and will now supply excitatory inputs to the ipsilateral motor neuron. And that's why it's still ipsilateral motor control. Okay? And that is your dentothalamic. So your dentothalamic, again, will synapse to the opposite thalamus. From the thalamus, it will synapse from the cerebral cortex. The cerebral cortex will now send signal to the via corticospinal tract. And then your corticospinal tract will cross in the midline to supply the ipsilateral motor neurons in the spinal cord. Okay, next we have your fastigial vestibular. So this one is specific for the extensor muscle tone. Okay, extensor muscle tone. So it will originate from the fastigial nucleus. And then mainly it will go to mainly ipsilateral and to contralateral vestibular nuclei. And then also will pass through the vestibulospinal tract to ipsilateral motor neurons. So this one is the vestibular nucleus. Synapse siya dyan. Some will go sa other contralateral, but most or mainly magsa-synapse with the ipsilateral, and then from the vestibular nuclei via your vestibulospinal tract, it will now support the ipsilateral motor neurons in the spinal cord, and then the spinal cord will send signal to the muscle, specifically mga extensor muscle. Okay, so fastigial vestibular extensor muscle tone. Next, we have fastigial reticular. If we have vestibular, we have reticular. So this one influences ipsilateral muscle tone. Okay, so no specific type of muscle. So this originates from the fastigial nucleus, and then it will synapse to neurons of reticular formation, forming the reticulospinal tract down to the ipsilateral motor neurons of the spinal cord. So now, after all of those anatomical discussion and pathways, let's now discuss the cerebellar dysfunction. So these are the manifestation seen in patients who are suffering with a cerebellar affectation. So now we have your dysarthria, which is your slurring or scanning speech. So problem with speaking. You have your dystaxia, a lack of coordination in the execution of voluntary movement. You have your gait, trunk, leg, and arm dystaxia. We have dysmetria, the inability to arrest muscular movement at the desired point. So yung example ko nga kanina, you have the finger to nose na test, no, to assess your dysmetria. So pass pointing between 2 points. Then you have your intention tremor, which is a type of dysmetria that occurs during a voluntary movement. Next, we have the dysdiadochokinesia, the inability to perform rapid alternating movements. So example is rapid supination and pronation of the forearm. You have your nystagmus, is a form of dystaxia consisting of to and fro eye movement. So yung nagkakaroon ng oscillation in the eyes. Then you have your decomposition of movement by the numbers phenomenon, which consists of breaking down a smooth muscle act into a number of jerky, awkward component parts. Then you have your rebound or lack of check. This results from the inability to adjust to changes in muscle tension, caused by loss of the cerebellar component of the stretch reflex. This may be tested by having the patient flex the forearm at the elbow joint against resistance. Sudden release results in the forearm striking the patient's chest. So, this is another way to assess your rebound or check reflex. Next, we have hypotonia, which is decrease in muscle tone. So this is loss of the resistance of the normally offered by muscles to palpation or passive manipulation. And then we have this equilibrium, loss of balance characterized by gait and trunk dystaxia. And then the reflexes are also affected with your cerebellum. Tendon reflexes may be diminished. So this is specifically hyporeflexia, meaning diminished reflex. Alternatively, tapping a tendon may result in oscillating movements of the part concerned, like a pendulum. Now let's have an example of your dysmetria, dysdiadochokinesia, and rebound phenomenon in this video.
We're going to be testing you for dysmetria. What I'm going to do is I'm going to give you this pen cap, and what I want you to do is just put the cap back on the pen right here at the tip. Alrighty, perfect. Now what I would like you to do is I want you to put your finger on your nose and bring it to the tip of my pen. Okay, one more time for me. Perfect, and one more time. Awesome, you did great. Okay, so what I'm going to have you do is I'm going to give you this pen cap, and what I'd like for you to do is just bring the pen cap and put it back on the pen for me. Alrighty. Now I'm going to have you take your finger to your nose and bring it to the tip of my pen. Okay, one more time. Okay, and one more time.
Okay, so as defined earlier, dysmetria is an inability to judge the distance and you overshoot or undershoot the target of an object. So a functional activity for that would be feeding. If you have dysmetria, you are unable to get the food onto your fork or spoon, and you have difficult time bringing it to your mouth because you overshoot or undershoot the target.
Okay, so what I'm going to have you do is I'm going to have you flex your arms at 90 degrees, and I want you to flip your hands back and forth like this. Do rapidly. Perfect. Great job. Okay, so I want you to tuck your elbows in at your side, and I want you to rapidly just flip your arms up and down like this. Alrighty. So functional activity for dysdiadochokinesia would be screwing in a light bulb. So if a patient wants to screw in a light bulb, normally obviously they would be able to pronate and supinate their arm like this. But if they were experiencing dysdiadochokinesia, they would just, if this is the light bulb, they would be like, just wouldn't work. Okay, so what I want you to do is I want you to put your arm at your side here. Keep your eyes open. I'm going to put some resistance and I want you to lift your arm up against my hand. Perfect. Okay, this time we're going to do the same thing again. I just want you to close your eyes. Beautiful. Okay, so what I'm going to do is I want you to keep your eyes open. I want you to put your arm at your side. I'm going to put some resistance on your forearm and just lift up against my hand. Okay. We're just going to do that one more time, but I want you to keep your eyes closed this time. Okay. That's that. So a functional activity for the rebound phenomenon would be opening the door. So if Sarah was experiencing difficulty in the rebound phenomenon, she would just, the door would slam her in the face. This is because of her muscles' inability to regulate the opposing action. So what I'm going to have you do is I want you to keep your eyes open. Text message.
Okay, so that's the examples of your dysmetria, dysdiadochokinesia, and your rebound phenomenon. So I hope you appreciate it more through this video. So this is the summary of connections in the cerebellum. Again, your cerebellum receives afferent information concerning voluntary movement from the cerebral cortex and spinal cord, from the muscles, tendons, and joints, your vestibular nerve concerning the balance, your tectocerebellar tract concerning sight, and this will go to the cerebellar cortical or cortex. No? So all information is fed into the cerebellar cortex by the mossy and climbing fibers, which are the excitatory inputs to your Purkinje, right? And converges on the Purkinje cells. From the Purkinje cells, it will project with few exceptions to the deep cerebellar nuclei. Diba? Your Purkinje cell will now inhibit your deep cerebellar nuclei. And then output of the vermis will project specifically to the fastigial nucleus, while the output of your intermediate regions of the cortex will project to the globose and emboliform nuclei. An output of the lateral part of the hemisphere will project to the dentate nucleus, while a few will end in the vestibular nucleus in the brainstem. Okay, so now we're done with the cerebellum. Let's proceed with the basal ganglia. So do not be confused with basal ganglia. This one is situated in the cerebral cortex. Okay, it's not in the cerebellum, it's in the cerebral cortex. But it also plays an important role in the control of posture and voluntary movement. The difference is that it has no direct or input or output connections with the spinal cord. Okay, kasi your cerebellum, diba, it has pathways going to the spinal cord. Diba? It sends signals to the muscle and joints via your spinal cord. So your basal ganglia, it has no direct input or output. So it can communicate with the muscles via an indirect connection. Okay, so your basal ganglia, it's a collection of masses of gray matter situated again in the cerebral hemisphere. So according to Snell, these are your these are those masses. You have your corpus striatum, amygdaloid, and your claustrum. For Waxman, you have your caudate nucleus, putamen, and globus pallidus. So, some books, no, they have different names or terminologies to describe this part of your basal ganglia. So, it's in this table. You have caudate nucleus, same lang siya, no, mostly. With lentiform nucleus, this is a collection of your globus pallidus and putamen. Claustrum will be the same. Corpus striatum, this is the collection of caudate nucleus and lentiform nucleus. Your neostriatum, or simply called striatum, this is caudate nucleus plus putamen. And then you have your amygdaloid body. For some reference, they use amygdaloid nucleus. So later in this discussion, we'll further identify these specific mass found in the basal ganglia. Okay, so but before we proceed, just an additional information, no? The striatum or the neostriatum, this is the major site of input to the basal ganglia. Okay, so remember that your striatum is the major site of input to the basal ganglia. So again, this is a collection of your caudate and putamen. So they receive afferent signals, no, via your corticostriate projections from the cerebral cortex, especially the sensory motor cortex. And then the caudate and putamen will send inhibitory axons to the inner part of globus pallidus, which is your major outflow nucleus of the basal ganglia. So this one is the major outflow nucleus. Okay, so your caudate and putamen will send inhibitory axons. So signal inhibitory to the globus pallidus, which is again the major outflow of your outflow nucleus of your basal ganglia. So these projections will provide a strong inhibitory input to your globus pallidus. Your globus pallidus, this one receives input from two major nuclei, your striatum and the subthalamic nucleus. Okay, and then project fibers, it will project fibers to three major nuclei, your subthalamic nucleus and your thalamus. So, your subthalamic nucleus, this receives input from the globus pallidus and from the motor cortex. Later, we'll have a organized discussion of this connection. And then, your subthalamic nuclei, your substantia nigra, and your red nucleus, they are functionally close to your basal ganglia, but they should not be included with them. So, may connection sila and may synapses sila with your basal ganglia, but they are not included in the basal ganglia. So now we have the four main components of your basal ganglia. We have the caudate nucleus, the putamen, the globus pallidus, and the amygdala. So I want you to remember the groupings of these basal nuclei. So we have first the striatum or your neostriatum, which is a collection of your caudate nucleus and putamen. Your lentiform nucleus, you have your putamen and the globus pallidus. And for your corpus striatum, it's the lentiform plus caudate nucleus. Okay, so nung student ako, one way to memorize this one, yung lentiform, si Len ay PG. Len daw patay gutom. So, lentiform, putamen plus globus pallidus. So, we'll discuss further the actions or functions of these structures later on in the discussion. Okay, so now let's talk about your substantia nigra and your subthalamic nuclei. Okay, so this one, they are not part of your basal ganglia. So the only components of your basal ganglia are your caudate, your putamen, and your lentiform nucleus, plus your globus pallidus. No, but this one, your substantia nigra and your subthalamic nuclei, they are not part of those. No. However, because of their anatomical location, they have function between your basal ganglia. Especially later with the motor pathways, you will appreciate them more. So your substantia nigra and your subthalamic nuclei, substantia nigra, it will have an excitatory input to your basal ganglia, while your subthalamic nuclei, it will also have an excitatory input to your globus pallidus. So later again, we will further discuss this. Okay, so we have now the circuitry of control of movement with your basal ganglia. So I want you to remember this because this is what makes our motor activity coordinated and smooth. So we have two pathways, which are your direct pathway and your indirect pathway. So when we say direct pathway, this will result to an excitation of your motor cortex. Okay, again, direct pathway, this will result to an excitatory stimulation to your motor or to your cortex. While your indirect pathway, this will naman produce inhibitory output to your motor cortex. Okay, so knowing this, there is an excitatory and an inhibitory stimulation from your basal ganglia. This shows that there is a balance of activity. So that this pathway will then be able to dictate if there will be either an increase or a decrease in the tonic inhibition from the globus pallidus. Okay? So, meaning then, it is why when we produce a skill or an activity, say for example, reaching for a glass of water, smooth and controlled yung transition natin nun. That is because of these two pathways. There is an excitatory and inhibitory stimulation going on in both, going on in one action, to produce one action smoothly. So later on, we will discuss further yung direct pathway and indirect pathway. But what I want you to remember first before we proceed are the functions of each of this that are contributing to this circuit of movement. So let's start with your putamen and caudate. Now remember, diba, putamen and caudate, collectively they are known as your striatum. Right? So first, what is the function of your striatum? So the function of your striatum is to inhibit. Who? Inhibit your globus pallidus. Okay? Both internal and external. Your globus pallidus kasi guys, yung internal and external, it's just the location of the globus, yung part ng globus pallidus, no? It has an internally located side and then an externally located side. And so, your striatum, it will inhibit both. So, the whole globus pallidus. Now, next, anong function ni globus pallidus internal? So, this one will inhibit thalamus. Okay? Or, isa pa niyang function is to produce tonic inhibition. Okay? Next, we have globus pallidus external. This one naman will inhibit, puro sila inhibitory, diba? Inhibit your subthalamic nucleus. Okay? So, aside from that, what is the function of your subthalamic nucleus? This one will produce or excite globus pallidus internal. Okay? So, yan muna, no? Para later, mabilis na natin ma-pick up paano nangyari yung excitatory output and inhibitory output. Okay? So, let's move on to the next slide. So, now we have the direct pathway. Again, your direct pathway, this will result to excitation of the cortex. No? Pag sinabi natin excitation of the cortex, it will therefore produce an action. Or muscle contraction. Pwede rin, di ba? Okay, so direct pathway, both pathways, no, they will start from the cortex and the substantia nigra. Now, so with the direct pathway, it will have an excitatory stimulation from the cortex and the substantia nigra going to the basal ganglia via your striatum. Okay, again, your striatum, this is your caudate and putamen together. No, so, ang gagawin nila, is-stimulate nila to, si striatum. Gawin mo yung trabaho mo, striatum. Ano nga ulit yung function ni striatum? Is to inhibit the globus pallidus. So now, striatum gets a signal that you can inhibit the globus pallidus. So, pag in-inhibit niya si globus pallidus, sabihin, ibablock niya si globus pallidus. O, huwag ka munang perform ng action mo. So, block si globus pallidus. And what is the action again of your globus pallidus? Is to inhibit thalamus, diba? Or produce tonic inhibition. So, since wala na tong function, walang magi-inhibit kay thalamus. Meaning, sige, thalamus, gawin mo yung action mo. So, there would be decrease in the tonic inhibition and there would be excitation na of your thalamus. Kasi walang nag-i-inhibit kay thalamus. So, sabihin, sige, okay lang mag-function ka. And that would result to increase firing to the motor cortex, leading now to muscle activity or motor activity. So, basically, your direct pathway will receive excitatory input and will produce excitatory output, causing now muscle movement. Okay, or contraction. Okay, so that is for your direct pathway. Now, let's move on with the indirect pathway. So, again, pag indirect pathway, this will produce inhibitory output. So, inhibitory output to the cortex. So, sabi ko nga kanina, both of these pathway will start from the cortex and substantia nigra. So, pwede rin yan with substantia nigra. So, still, it will start with an excitatory stimulation. So, ganun ulit, i-excite nila si striatum, no? Or, i-excite nila si basal ganglia via the striatum. Sige, gawin mo ulit yung action mo. Inhibit mo ulit, but this time, since this is indirect, you inhibit external globus pallidus. Okay? So, the function now is to inhibit external globus pallidus. So, pag in-inhibit niya to, huwag ka munang mag-action. Ano nga ulit action ni pallidus? Ni globus pallidus external is to inhibit subthalamic nuclei. So, kung walang function to, meaning, walang magi-inhibit kay subthalamic nucleus. So, positive to. Sabihin, sige, gawin mo lang yung action mo, subthalamic nucleus. And the action of your subthalamic nucleus is to excite your globus pallidus internal. So, therefore, it will produce excitatory input to the internal globus pallidus. And what is again the function of your globus pallidus internal? To produce tonic inhibition. And that will, and also, inhibit thalamus. So, ngayon, pwede mo nang gawin yung action mo, globus pallidus internal. So, inhibit si thalamus, and that will result to decrease firing to the motor cortex. And it will result to tonic inhibition plus negative muscle activity. Okay? So, kay indirect pathway, there is an excitatory input but inhibitory output. Okay, and that is because of your globus pallidus internal. Okay? In the next slide, meron pa ulit tayo isa pang way, no? Para ma-remember tong pathways natin. Again, no, one more time. For the direct pathway, this will result to an excitatory output to your motor cortex. So, it will start with your cortex and substantia nigra sending excitatory input to your striatum. Your striatum is an inhibitory, will send inhibitory input to your globus pallidus internal. So, wala ngayon tong action, wala tayong tonic inhibition. Therefore, mas-stimulate si thalamus to do its job, which is to excite the motor cortex, producing now your muscle activity. Okay? So, now we have the indirect pathway. Pag indirect, nandito na si external globus pallidus plus subthalamic nucleus. No? So, this pathway, again, will start with your cortex and substantia nigra. Excitatory input pa rin yan to the striatum. It will therefore inhibit your external globus pallidus. Anong action ni globus pallidus external? Is to inhibit subthalamic nucleus. So, walang nag-inhibit kay subthalamic nucleus, meaning it will produce excitatory input to the globus pallidus internal, which will inhibit your thalamus, diba? And produce now tonic inhibition, okay, to the motor cortex, and that will result to negative muscle activity. Okay, so these are your direct and indirect pathway for the basal ganglia motor circuitry. Again, this is another way, no? So, direct basal ganglia pathway, you start first with the motor cortex and the substantia nigra, particularly the pars compacta. So, they will send excitatory signals. So, si motor cortex, it will send via your glutamate neurotransmitter, while your substantia nigra is your dopamine. So, yan. Kaya, makikita nyo with your Parkinson's disease, it's an extrapyramidal system problem or lesion or problem with the basal ganglia because of the decrease in the dopamine. Diba yun yung problem with Parkinson's disease? So, nagkakaroon ng problem with the activity dito sa pathway natin. So, they will excite your striatum, which will inhibit your globus pallidus internal. No? So, your globus pallidus internal cannot do its function, and therefore, your thalamus will be able to excite your motor cortex. No? So, increase excitatory signal via the glutamate, and that will produce your muscle movement. Okay? So, direct pathway again, excitatory ito. Okay, and lastly, we have your indirect basal ganglia pathway. So, pag indirect, inhibitory output, no? Inhibitory output. So, again, it will start from the motor cortex and the substantia nigra, stimulating again your striatum. So, once stimulated, this time, it will inhibit your globus pallidus external. So, globus pallidus external will not be able to inhibit your subthalamic nucleus. So, tuwang-tuwa si subthalamic nucleus because it can now excite your globus pallidus internal. Your globus pallidus internal will then inhibit your thalamus. So, si thalamus cannot do its work. It will then now lead to less excitatory signal or decrease in the excitation, or it will result to tonic inhibition or decreased movement to the muscle. So, that is how your indirect basal ganglia pathway is inhibitory. Okay, so now let's move on with the movement disorders. Now that we're done identifying the pathways involved in motor activity, smooth motor activity, ng mga function natin. So now, let's have the movement disorder. So this will result with basal ganglia lesion. So we have two types. We have hyperkinetic and the hypokinetic disorder. But what is this? Pag hyperkinetic, meaning increase in the movement. Hypokinetic, decrease in the movement. Okay, so dystonia, we have dystonia, problem with maintaining the tone of a posture. Okay, so that's dystonia. So, minsan makikita nyo sila naka-twist yung mga arms nila. Statically lang naka-twist yung arms nila. So, that's dystonia. You have tremor. So, tremor, we have two types of tremor. Wait. We have resting tremor and we have intention tremor. So, this is a very important thing to remember, no? Kasi, these tremors are an affectation of two different structures. When we say resting tremor, the tremors are visible at rest. Okay, so for example, nakapatong lang yung kamay nila sa table, yan. Makikita nyo nagte-tremors yung kamay nila. Pag tremor, this is like oscillating movement. Nag-oscillate yung limb or hand nga, for example. That's tremor, nag-shake. So, for the resting, you can observe this at rest, no? For intention naman, this can be seen upon activity or upon movement. Okay. Now, what I want you to remember is that resting tremor, this can be seen with basal ganglia lesion. Okay. While your intention tremor, this is seen for your cerebellar. Okay, di ba remember yung mga tremor natin? This is problem with coordination. Di ba? And one function of your cerebellum is also for motor coordination. Okay, so do not forget, no? Kapag resting, at rest, kapag intention, upon movement. Okay, and resting, this is basal ganglia lesion. Intention tremor, this is cerebellar lesion. Okay. Next, we have tics. Pag tics, this is involuntary movement, usually seen in the face, no? Yan, yung mga nagtitik. Okay. And then we have myoclonus. So, with the myoclonus, these are repetitive motion of a muscle group. Usually, this is triggered by stretch reflex. So, in the next slide, I think mas madidiscuss natin yung myoclonus. Spasticity, this is a type of hypertonicity. But the difference with this one, kasi, yan. Tatanungin kayo, what is the difference between spasticity and hypertonicity? The difference is that with spasticity, this is velocity dependent. Okay. While your hypotonicity, increase lang yung muscle tone niya upon passive movement. Regardless of speed, change of speed. With spasticity kasi, lumalabas lang yung hypertonicity niya upon changing the speed of the movement. Okay, kaya siya tinawag na velocity dependent. Okay, so those are the differences between your spasticity and your hypertonicity. Okay, chorea, this one is, sabi natin kanina sa SC gash nyo. Diba? Chorea, this is found in striatum. So, these are jerky movements, no? Your chorea, this is jerky movements, quick, jerky, irregular movements that are non-repetitive. This usually affects the proximal, no? Proximal joint to, si chorea. Involves the proximal limbs or joints. Okay? So, palatandaan namin dyan is chorea para daw siyang sounds like Korea. Diba madaming mga boy band na sumasayaw sa Korea. So, yan, no? Chorea kasi para siyang nagda-dance, nagja-jerky movements of the proximal parts or segments. Balismus, this one is, or also known as hemibalismus. This is violent flinging movements. No, so, sa mnemonic natin, ito yon, hemibalismus. This is affectation of the subthalamic nucleus. Okay, so large amplitude yan. No? Large amplitude, yung bigla-bigla na lang nagfi-fling yung arm niya. That's balismus. Akathisia, this is subjective restlessness. So, pag sinabi natin subjective restlessness, sinasabi lang siya, kino-complain lang siya ng patient. No? Hindi siya nakikita talaga objectively. So, sinasabi ng patient, parang di ako mapakali, gusto ko lagi akong gumagalaw, that's akathisia. No? Or parang gumagalaw yung katawan ko, that's akathisia. But then, if you look at them objectively, there are no signs of nagsishake sila or restlessness. That's akathisia. And usually, akathisia is a side effect of common mga antipsychotic drugs. Yan, si akathisia. That's a common side effect. Then we have your athetosis. Athetosis consists of slow, writhing movements. Now, this one naman commonly involves the distal segments. Now, versus your chorea. Your balismus also proximal din to, if I'm not mistaken. Okay. So, athetosis, this one is distal. So, ang palatandaan namin dyan is parang worm-like. Worm-like. Yan. Kapag sa right upper extremity siya, para siyang worm. Tapos magsa-start siya distally. So, slow, writhing movements, no? That commonly involves the distal segments. And this one, nasa mnemonic pa rin natin yan. Ito yan. Athetosis, this is globus pallidus. Affectation of the globus pallidus. Okay. So, next we have the hypokinetic disorder. So, we have the bradykinesia, which is slowness of movement, slowing of movement. This, ito, lahat to actually are manifestation of Parkinson's disease. So, slowness of movement. Yan, they have difficulty initiating and performing new movement, bradykinesia. Freezing, from the name itself, nagfi-freeze sila, no? So, sudden change in activity, yan, it will cause them to freeze. For example, naglalakad sila, and then, suddenly may tumawag sa kanila, tinawag yung name nila, so napaluk sila to the left. And then, from there, yung pag-turn na yun, sudden turn, magfi-freeze sila. Okay, that's an example of your freezing, no? Rigidity, this is also an example of hypertonicity. But there is a difference, no? Between spasticity and rigidity. Sabi natin kay spasticity kanina, it's velocity dependent. How about rigidity? So with rigidity, this one is, hindi na siya velocity dependent. But the problem is this one is that you can no longer move the limb. No? So, fixed posture na or moving the limb is impossible. Okay. So, for example, no, naka-flex yung elbow. Sa mga stroke, diba, usually naka-flex yung tinatawag nating typical arm posture, naka-flex yung elbow. So, paano natin malalaman kung spasticity or rigidity yan? So, ipapassively move natin yung elbow towards extension. Now, if hindi natin magalaw talaga, no, tinry natin, ayaw gumalaw, para siyang stuck na talaga, that is your rigidity. No? But if gumalaw siya, okay, pero medyo nagalaw siya, pero nararamdaman nyo na may humihila or pumipigil, no? That could be hypertonicity. But if you want to confirm if there is spasticity, kailangan nyong i-assess kung velocity dependent. So, bigla nyo siyang quickly i-extend yung elbow. Kailangan mabilis, no? That will cause now, trigger to the stretch reflex again. So, kapag bigla nyong in-extend yung elbow niya, tapos biglang nag-stop, that is positive for spasticity. Okay? Aside from that, your rigidity has two types. Wait lang. You have your cogwheel, yan, and your lead pipe. Okay? Yung example ko kanina, that is your lead pipe. No? Yun yung hindi mo na talaga magalaw. Or no, sorry. Okay, rigidity yan, kapag hindi mo na talaga magalaw. No? Lead pipe is strong yung resistance niya. No? There is positive resistance. Yun na lang. Positive resistance all throughout the range of motion. Okay? Meaning from the starting position, tinatry nyo siyang i-extend, equally same yung resistance. That is lead pipe rigidity. Cogwheel, so from flex position, di ba? In-extend mo, pag-extend mo sa kanya, magsa-stop siya, tapos biglang luluwag. Stop, biglang luluwag. So, parang siyang cogwheel. So, nag-alternate na yung resistance. So, alternating, so dito may resistance, dito may resistance, biglang wala. Resistance, biglang wala. Resistance, biglang wala. So, cogwheel rigidity yung tawag doon. Okay, so sino yung mas severe? It would be your lead pipe. No? Kasi all throughout the movement na may resistance against passive motion. Okay? Kasi diba muscle tone is the muscle's ability to resist passive motion. Okay, do not forget that. And then lastly, we have your postural instability. Okay, your postural instability, this may be contributed by stoop posture, which is common sa mga may Parkinson's disease. No, they have small short steps sila pag naglalakad. Yan, causing now increased risk for fall. And also, ito yung mga nagiging cause kung bakit sila may balance problem. Ayan, so that would lead to postural instability. So, stoop posture, tas naka-flex pa yung hip and knee nila, tapos short pa yung step nila pag naglalakad. Diba? And then, slow pa yung movement nila because of the bradykinesia, and then nag-freezing pa sila. Those are your postural instability. Yan. Yung gait for the Parkinson's disease, you have your festinating gait. Mali yung spelling ko. Festinating. And then you have your shuffling gait. Okay. This is present with Parkinson's disease wherein they have short step nga. Okay. Ayan. So again, these are the movement disorders involving basal ganglia lesion. So chorea, this is brief, rapid, forceful, dysrhythmic, discrete, purposeless flinging of limb, specifically of the proximal. Diba? Proximal. So affectation nito is the putamen or the striatum. Okay. Next, we have the athetosis. So, slow writhing. So, worm-like. No? Inability to maintain position. Now, this one involves the distal segment more. Okay? So, this affects naman your globus pallidus, balismus or hemibalismus. This affects your subthalamic nucleus. This is large. Yun yung alalahanin nyo. Large amplitude flinging movement of limb. This one usually proximal. Same sila ni chorea. And then your dystonia, this is sustained muscle contraction that leads to repetitive twisting. Yan. Twisting movements of variable speed and abnormal posturing. Okay, so what I want you to remember is that this one, sustained yan. Yung muscle contraction nila. Meron silang abnormal twisting posturing. Usually nga sa arms nyo makikita yan. No? And then we have tremor. So this is rhythmic oscillatory movements of a body part. Again, I've mentioned na yung two types. You have your resting and your intention tremor. Resting tremor, this is basal ganglia lesion. Your intention tremor, this is for cerebellar lesion. Para matandaan ko nyo din, no? Kasi ako nung student ako, litong-lito ako. Hindi naman sa lito. Hindi ko sila matandaan kung kanino ba si resting, kung kanino si intention. No? So, pag palatandaan ko lang, resting, ang una kong naiisip is Parkinson's disease yan. So, rest, palatandaan ko is pagod. Okay, so pagod, PD, Parkinson's disease, ayan. Resting, tremor yan. And then, of course, yung isa, intention tremor, doon na yun sa kabila. So, intention tremor, cerebellar affectation. And then we have your tic, which is intermittent, repetitive, stereotypical, abrupt, jerky. Again, typically found in the face and in the head. Yung mga biglang nagro-rotate yung neck, that's mga tic yun, no? Intermittent. Stereotypy, these are purposeless, uniformly repetitive, voluntary movement of whole body areas. So, paulit-ulit, no, na ginagawa voluntarily of the whole body. No, stereotypy yung tawag doon. Akathisia, this is again subjective. Restlessness, compulsion to move about. Yun, mga hindi mapakali. That's akathisia. Myoclonus, this is sudden, brief, irregular contraction of a group of muscle. Again, this is usually triggered by stretch reflex. Okay. So, si myoclonus, I'm not sure if this is myoclonus yung ginagawa ng parang hindi naman, no. Kasi walang stretch reflex, no. But this is commonly seen with mga stroke patients. Specifically sa ankle. So, for example, this is the ankle. This is the anterior. This is the posterior. This is the gastrocs. No? Kung stretch reflex yan, the position of the ankle that will stretch the gastrocs is towards dorsiflexion. So, if you want to elicit a stretch reflex, you move the ankle towards dorsiflexion quickly. No? Kailangan rapid yan. No? Abrupt, rapid change yan. So, pag pinasively dorsiflex nyo yan, ang mangyayari, magpa-plantar flex yung ankle nito, involuntarily. Magpa-flap yung ankle niya to plantar flexion, dorsiflexion. So, nagpa-flap yan, gumagalaw yan, gumaganyan. And that is your myoclonus, meaning nagko-clonus na siya. Okay, your clonus actually is also an abnormal response to mga deep tendon reflexes natin. Again, this is seen sa mga may upper motor neuron lesion. Okay, so hindi nakokontrol ng brain natin yung response ng muscle natin to the stretch reflex. Kaya nagkakaroon ng myoclonus. Okay, now that we're done with the movement disorder, your basal ganglia and your cerebellum, let's now move on to the extrapyramidal system. Now, your extrapyramidal system, this is basically similar to the pathways that we've described earlier, no? Kasi this still involves your basal ganglia. No, but with extrapyramidal system, the only different thing with this one is that this does not involve your corticospinal tract. Okay? Kaya siya extrapyramidal, no? Outside the pyramidal tract. Diba your pyramidal tract consists of your corticospinal tract. Okay? So with this one, this refers to all the descending tracts other than the corticospinal tract. Okay? Which also has a function when it comes to motor activity, specifically mga tones, no, in maintaining mga motor control and motor tones natin, muscle tones. No, so if you have a problem with the basal ganglia, you will therefore have a problem with the extrapyramidal system. So if you have a lesion with this one, you can also present with the movement disorders that we have discussed earlier. So now these are the parts, no, that consist your extrapyramidal system. So these are your striatum, your subthalamic nucleus, your substantia nigra, your thalamus. So kanina yan yung kasama sa pathway natin sa basal ganglia. So included din sila with the extrapyramidal system. But now we have your red nucleus, your brainstem reticular formation, your descending spinal cord tracts, except for the corticospinal tract, and which are your vestibulospinal, rubrospinal, tectospinal, and reticulospinal tract. With your ito yung basal ganglia natin, di ba kanina? Ayan, dyan umabot yun. So, this is important for the inhibition and excitation, no? To produce activity. Okay, your red nucleus, this has a function with facilitating mga tones. Later on in the discussion, we'll specify kung ano yun, no? So, it can facilitate and inhibit also certain muscle groups, your red nucleus. Your reticular formation, this one has so many functions, no? Kasi aside from the motor system, it can also have an effect with the autonomic nervous system as to the sympathetic and parasympathetic outflow. And aside from that, meron pa siyang function as to consciousness. So, medyo madaming ginagawa or madaming kayang gawin si reticular formation. But for this one, extrapyramidal system, it has something to do again with the motor tone, no, mga muscle tone natin, and coordination. And then, ito yung mga tracts that they will be forming. Your vestibulospinal tract, we will discuss this later on. But this one has something to do with your vestibular nuclei. Okay, so let's move on with the first nucleus, no? Okay, so let's move on with the red nucleus. No? So the red nucleus, as I've mentioned earlier, this has something to do with facilitating and inhibiting certain muscle groups. No? So the red nucleus, this is situated in the tegmentum of the midbrain at the level of the superior colliculus here. So this receives afferent impulse through connection with the cerebral cortex and cerebellum. No? Afferent yan. And then, it will form your rubrospinal tract by crossing the midline. Ito, crossing the midline through the pons and the medulla oblongata. Pupunta siya sa spinal tracts. Ayan, in the white column of the medulla. Okay, so what I want you to remember with this one is that this tract, your rubrospinal tract, will facilitate the flexor muscle groups. Okay, facilitate flexor, inhibit extensor, or your anti-gravity muscle. Why am I saying this, or why am I emphasizing this? Because you have another tract which also does the opposite of this. Okay, so again, your rubrospinal tract, it will facilitate flexor muscle group and inhibit extensor muscles. Okay, now we have vestibular nuclei. So this one is what I was talking about. So with this one, this is situated in the pons and medulla beneath the floor of the fourth ventricle. So this receives afferent fibers from the inner ear and through the vestibular nerve and from the cerebellum. Okay. And then neurons of the lateral vestibular nucleus will give rise to the axon to form your vestibulospinal tract. Okay. So your vestibulospinal tract, this one naman will facilitate extensor muscle, also known as your anti-gravity muscle, while it will inhibit flexor. Okay? Aside from that, it plays an important role in maintaining erect posture. Okay? So, vestibular nuclei, diba, pag vestibular system, it has something to do with balance, no? So, if we want to have good balance, kailangan maganda yung posture natin. Makes sense, diba? So, vestibulospinal tract, it has an important role with maintaining erect posture. And how is that? It's by facilitating extensor or anti-gravity muscle. For example, ng extensor muscle natin is your erector spinae. Diba your erector spinae is a trunk extensor. So, if your vestibulospinal tract will facilitate the trunk extensor, you will have an erect posture. Diba? It makes sense. So, that is your vestibulospinal tract. Okay? So, meron na tayong rubrospinal tract and vestibulospinal tract. Now, let's move on with the tectospinal tract. Okay? So, this one is came from nerve cells in the superior colliculus of the midbrain. Diba pag superior colliculus of the midbrain, it has something to do with the visual system. Okay. So, the fibers of this tract came from, ayan, sa eye nga. Ayan. Okay. And then, this tract will descend through the anterior white column of the spinal cord close to the anterior median fissure. Majority of the fiber terminate in the anterior gray column and the upper cervical segments of the spinal cord by synapsing with internuncial neurons. Okay. It is believed to be concerned with reflex postural movement in response to visual stimuli. So, palatandaan ko nung student ako is tecto. Pag sinasabi ko siya, it sounds like neck. Diba? Ewan ko. Sa akin ganun. Tecto, neck. Neck. Okay? So, inaalala ko siya na it will terminate at the upper cervical, which is the neck. No? Upper cervical segment, plus yung function nito is reflex siya for visual stimuli. Okay, reflex postural movement in response to visual stimuli. Example nito is pag tatawid ka, kunyari, or hindi, naglalakad. Tapos may nakita kang kumidlat bigla sa left side mo, kumidlat. Tapos ang reflex mo is titigin ka kung saan nanggaling yung ilaw, no? So, sino yung gumalaw doon? Yung neck, diba? So, visual stimuli, reflex postural movement in response to visual stimuli. Bigla kang napatingin, tas nagulat ka. So, that is your tectospinal tract. Next, we have the reticulospinal tract. So, bakit mali-mali yung spelling ko, no? Reticulospinal tracts. So, these are group of scattered nerve cells and nerve fibers existing throughout the midbrain, pons, and medulla oblongata, which are collectively known as your reticular formation. So, sabi ko nga kanina, ang daming function ni reticular formation, and that's because these are groups of scattered nerve cells and fibers. No, madami talaga tong function. So, it can be divided into two. You have your pontine reticulospinal tract and your medullary reticulospinal tract. Okay? So, this one naman, it will influence voluntary movements and reflex activity. No? And aside from that, nabanggit ko kanina, it also has a connection with the ANS. Paano ba sila nagka-connection with the ANS? It's because of their relationship with the hypothalamus. Remember your hypothalamus, it has connections with your ANS. So your reticulospinal tract, it can also produce your it can also control the sympathetic outflow and sacral parasympathetic outflow. Okay, but in general, your reticulospinal tract, this one influence the voluntary movements and mga reflex activity natin. Okay, so that would be for your reticular formation. This one, wala masyadong specific na anong muscle group yung mga kinokontrol, no? But this one, voluntary movement, yung kaya nilang i-influence. Plus the reflexes. Plus the ANS. Okay. The parasympathetic and sympathetic outflow. Okay, so this is another table showing you the main descending pathways to the spinal cord. So, extrapyramidal system yung topic natin, so hindi kasama to. Okay. Ayan. So, we have the reticulospinal tract. Ito yung madami masyadong function. So, it inhibits or facilitates, ayan, remember, voluntary movement. It has hypothalamus hypothalamus connection controlling now the sympathetic and parasympathetic outflow. Your tectospinal tract, it sounds like neck, diba? So, reflex, magkatunog din, reflex. Reflex postural movement concerning the eye or the sight, no? Your rubrospinal tract, it will facilitate flexor movement or muscle, and inhibits the opposite, extensor muscle. Your vestibulo, this one facilitates your extensor or your anti-gravity muscle to maintain erect posture. Your iliospinal tract, this is not part na, no? but yung function niya hindi pa known. And then descending autonomic fiber, hindi na rin to part ng extrapyramidal system. Okay, now we're done with that. Let's move on with the lesions of the extrapyramidal system. Actually, same lang siya with the movement disorders found with your basal ganglia lesion. But for this one, yung nakasulat lang dito, specifically condition na siya. So yung kanina ko pang paulit-ulit na mention, which is Parkinson's disease, no? Yan yung number 1 na sikat na condition with your extrapyramidal lesion. So Parkinson's disease, the problem with this one is found in the basal ganglia, specifically because of the dopamine. Sa dopamine yung problem niyan. Then we have Wilson's disease and your hyperkinetic movement disorder. Pwede rin pumasok dito si Huntington's disease. Huntington's chorea, it's the same with your chorea. In-specify lang nila na brought about by Huntington. Your Huntington's, this is affectation of the striatum. Degeneration to. Okay? Nagkakaroon ng degeneration with the striatum and therefore causing now your chorea. So, it's still a basal ganglia affectation or extrapyramidal lesion. Okay, so this is again your other manifestation with your extrapyramidal lesion. You have your bradykinesia, slowing of movement, hypokinesia, decreased amplitude of movement, akinesia, is absent, so lack of movement. So this can be found, especially your bradykinesia, for Parkinson's disease. Okay, and then we have other pa, hypokinetic, paucity of movement that is unrelated to weakness or spasticity. Hyperkinetic, excessive naman yung movement, and then you have your combination of both. So in this video, as you can see dito, ayan, nagte-tremor siya, 'di ba? But nawawala siya upon movement. So, what do you call this tremor? This is your resting tremor. Okay? So, sinong affected? Extrapyramidal. Correct, no? Si basal ganglia or your extrapyramidal. Okay? For this one, this is what you call your shuffling gait or fascinating gait. You can see, pag nakalakad na siya. Ayan. Very short steps, very, very short steps, no? Plus, meron siyang stoop posture, contributing to his postural instability, no? Nagbabago yung base of support niya because of this posture. No, aside from that, ito yung sinasabi nating problem with initiating an activity. Tagal niya bago siya nag-start, 'di ba? Okay. Not sure if nag-freeze siya dito kaya siya nag-stop. Wait. Usually, mag-freeze yung may Parkinson kapag may sudden change of movement. Siguro nag-freeze siya kasi nag-turn siya. Usually yan. Pag mag-turn, nagkukos ng, mga rotational yan, mag-turn siya, magkukos ng freezing yun. Pwede. Nag-freeze siya for a while. Okay, so these are the signs of your Parkinson's disease.
Okay, in summary, these are your manifestation. When it comes to upper motor neuron lesion, lower motor neuron lesion, extrapyramidal system lesion, and your cerebellar lesion. So, pag upper motor neuron lesion, palatandaan natin dyan, up, so lahat pataas, no? So, sa strength, they are, hindi malakas yung strength nila, no? So, paralyzed muna. So, paralyzed or paretic. Atrophy nila, there is positive atrophy, but this one, this is disuse atrophy. Now, versus your lower motor neuron lesion, this is severe, positive din siya, but this is now neurologic atrophy. Okay, pag sinabi natin disuse atrophy, lumiit lang siya kasi hindi nagagamit. Okay, disuse yon. Di ba, pag atrophy, this is luminipis yung muscle bulk, lumiliit. Di ba? Okay, so lumiit siya yung muscle niya, muscle size niya because of disuse. No, pag naman sa lower motor neuron lesion, nagkaroon siya ng atrophy because of neurological reason. Most of the time, ang reason niyan is because nagkaroon ka ng rupture with the nerve itself. So, for example, yung nerve na nagsusupply sa biceps mo, 'di ba pag lower motor neuron, peripheral nerves 'yan. So sino ba yung nerve supplying your biceps? It's your musculocutaneous, 'di ba? So if the musculocutaneous nerve becomes severed, magkakaroon ka ng inability ngayon to contract that muscle, and that led to atrophy. Wala na nagsusupply na nerve dun sa muscle na yon. Okay, so that is your neurologic atrophy. Okay, next, reflex. So sabi nga natin kapag upper motor neuron lesion pataas. So this one hyperreflexia, this one hyporeflexia. Hyper ulit pataas, hypertonic or spasticity, rigidity, yan. Hypotonic, yan, mababa. Wala tayong other name for hypotonic. Okay, flaccid, pwede din, no? Flaccidity. Pero your flaccidity, this can also be seen with your upper motor neuron lesion, specifically for stroke. So, dito na lang tayo. Mag-stick tayo sa term na hypotonicity. Next, we have abnormal reflexes, also known as your pathological reflexes. Ang pinakakilala, hallmark natin dyan is pag nag-positive siya with your Babinski reflex. Babinski. Okay. Dito naman, negative siya kay Babinski or pathologic reflex, but there is fasciculation and twitches. Sa kanya lang yan, no? So, pag may fasciculation and twitches, nakikita nyo yung muscle niya, for example, yung sa brachioradids niya, no, nagtutwitch, that's a sign of a lower motor neuron lesion. No, sa mga problems natin with peripheral nerves, or ano pa bang lower motor neuron natin, di ba? Spinal nerve roots. So kunyari, disc herniation, lumbar nerves, L4, L5 ang affected. So yung mga sinusupply niyang L4, L5, usually ankle dorsiflexors, ankle dorsiflexors, no? Ayan. And big toe extensors. Makikita nyo may weakness dyan. Plus, pwedeng makakita ng mga twitching. Na nagtutwitch. Meaning, di ba usually, if there is a sign of muscle twitching, that should alert you na there is muscle weakness. No, masyadong weak yung muscle, nagtutwitch siya. Okay, so that is a sign of your lower motor neuron and upper motor neuron lesion. Next, let's move on with ang medyo similar naman with each other is the extrapyramidal and the cerebellar. So, for the extrapyramidal system, yan, yung strength, wala tayong problem with muscle strength, no? Because again, with your extrapyramidal system, ano ba yung pinaka-pinoproduce nila? It's more on the coordination, diba, of an activity. Skill and coordination. So, with muscle strength, hindi nila trabaho yan. Iba na yung tracks for that. So, wala tayong problem with that. Okay? Atrophy, wala din. Kasi kaya niya pa rin galawin yan. Ano yung problema? It's the coordinated movement. Yun ang problem. Stretch reflex, this is also normal. No? Intact pa rin yan, yung mga stretch reflex natin. So, the tone can be rigid. Yan. Specific yan to basal ganglia. No? Rigid. No? And then, you have yung mga movement disorders natin such as dyskinesia. Yan. Yung SC gash natin. Yan. Extrapyramidal yan. No? So, versus your cerebellar. Cerebellar strength, wala din kinalaman sa muscle strength si cerebellum. Again, more of tone and coordination of movement din yan. Atrophy, wala din. Kasi kaya niya pa rin galawin yung muscle natin, no? Stretch reflex, normal yan. This one naman, hypotonic. Okay, si cerebellum hypotonic. And ano pang difference ni cerebellar affectation versus your cerebral? This one has an ipsilateral affectation, while your cerebral has contralateral. Okay, meaning, if left cerebral is affected, it will result to right hemiplegia. Okay, pag naman sa cerebellum, no? While in cerebellum, if it's the left cerebellum, So if left cerebellum, no, it will present with left hypotonia. Okay. So that is for your cerebellum, ipsilateral affectation. Aside from that, you have ataxia, problem with balance, 'di ba? We have dysmetria, problem with coordination 'yan. Precise coordination, dyssynergia and dysdiadochokinesia, alternating movements. So those are your abnormal movement disorder for the cerebellum. Okay? So that's it for your cerebellum, your basal ganglia, and your extrapyramidal system. Alam ko medyo overwhelming yung mga names. Sorry for that, especially for the anatomical locations, mga names. It's purely memorization, but I hope that the function naman is yung important, no? Na understood nyo in this lecture. So that would be all. Thank you and have a nice day.